Okay, welcome everybody. My name is Rena Lachlan, and I am the Vice President of Programs and Advocacy at the Epilepsy Foundation, Eastern Pennsylvania. Welcome to our annual Pediatric Epilepsy Conference. Thank you so much for joining us this evening. We have a great conference for you tonight. Before I welcome our first speaker, there are a few things I want to mention. So I am going to launch a poll. If you guys could take a minute to fill that out. Okay. And because this is a webinar, we cannot see you and we cannot hear you. So if you have questions for our speakers, you can place them in the chat and I will present them to our speakers after their presentation. So just a reminder that you are not alone. So 1 in 26 people will develop epilepsy at some point in their lifetime. 3.4 million people in the US have active epilepsy. And 6 out of 10 people who have epilepsy, the cause is unknown. And in Eastern Pennsylvania, there's about 110,000 people living with epilepsy. A little bit about the EFEPA. So we serve 18 counties in Eastern Pennsylvania, and we're really focused on providing education, support, and advocacy. We are here for you as we have been for a little over 50 years. So our programs and services are really wonderful and can be really helpful to the epilepsy community. We have seizure recognition and first aid trainings. We train school personnel, EMS, first responders, family members, anyone that wants training, we will train you. We have monthly support groups. Some meet virtually, some are in person. We have some advocacy efforts that we're working on. We have community and awareness events, educational conferences like tonight, and webinars, informational referrals. So you can work with a staff member to get resources and referral information. We have youth, young adult, and adult services. We have retreats and camp. We have Camp Achieve, so we'll talk a little bit about that later. And we have 3 mental health programs. Okay, so tonight, this is our conference schedule. I'll let you guys look at this for a minute. We will have a 10-minute break around 6:55, and then we will continue on our conference, and hopefully we will stay on schedule and we'll be ending at 8 p.m. Okay, so I want to welcome our first speaker of this evening, Lori Holdredge. She works at the Pennsylvania Office of Vocational Rehabilitation. So she's going to give us a good introduction to what they do and who they are. So I will pass it over to Lori. Let me stop share.
Thank you so much for having me. So my name is Lori Holdredge. I am with the Office of Vocational Rehab, and I actually work in our Wilkes-Barre office, which is our district office. We oversee 12 different counties in northeastern PA. So we service a lot of individuals. And today I thought to kind of talk about what OVR is, if anybody is not familiar with it. So I do have a PowerPoint that I'm going to share my screen. And I do have a delay, so I apologize for it taking a little bit longer to get up. Okay. Okay, so again, I said I'm with the Office of Vocational Rehab. Just trying to get it into the slideshow mode, so I apologize. Okay.
Yeah, it looks good, Lori.
Wonderful, thank you so much. Okay, so who are we? as I said, we are with the Wilkes-Barre office we're right downtown. We're on West Market Street. And why are you here? So all about OBR, we are here to help people work. And we work with individuals that have impediments to working. We want to help people get services and get them successful. So our mission to assist Pennsylvanians with disabilities to secure and maintain employment and independence. And what does OBR do? We provide services to individuals to help them prepare, secure, retain, advance in, or regain employment. So we're going to go over that a little bit more in detail when we talk about what we do. And who should apply? Pretty much anybody who has a disability or a health impairment. I always say I feel like everybody qualifies for OBR. So OBR, if you have a bad back or slipped discs and really are having a hard time working, to you have anxiety or depression, or you have epilepsy or autism or intellectual disabilities. So anything that would impede in working would get you qualified for OBR. And we want everyone to work. So if your goal is to work, we want you to work, and we're here to help. And so sometimes individuals have a really hard time getting a job when they have these disabilities. So our goal is to kind of work with you, see what would help, what would kind of go on, and what services would help you obtain that job. So pretty much, what is OBR's goal? Again, our goal is to help you obtain a job. Sometimes it's retention of a job too. So we have individuals that some things are happening due to their disability, and they really need help or services put in place to retain the job that they're already in. So we're going to talk about some qualifying factors for OBR. So sometimes you can't see a person's disability. So we work with individuals who have depression, anxiety, learning disorders, autism, traumatic brain injuries, diabetes, hearing loss or deafness, visual impairment, or seizure disorder. So I work with students who have learning disabilities. I work with individuals that have intellectual disabilities or autism. I work with people that have seizures or need hearing aids, and all of that qualifies you for OBR services. So one thing about OBR is we are very individualized. I always tell people that because some people are like, oh, how do I, get OBR, and what services do you provide? And it's really hard for me to say on the phone. I'm going to even today give you a brief overview of the services we provide, but they are so individualized, and we really rely on the information given by the participant. Individuals give us information from their school or from their doctor, or they self-report to us, and then we kind of come up with a game plan of what would work best for them. I did see the comment of what if somebody had a stroke? Absolutely, that would qualify them for OBR. We send people for testing sometimes that have a stroke, or I have an individual right now that has aphasia, so has a really hard time communicating. So we're getting some services and some equipment put in place to help them communicate in their workplace. Who do we work with? So OBR serves people of any working age. So I have individuals on my caseload starting from the age of 14 all the way up. And the nice thing about OBR is that you can have multiple cases in your lifetime with OBR. So you might be working with us at age 14, and usually individuals at age 14, we work with you in a group setting. We talk about, how to fill out a resume, how to go on an interview, good questions to ask on an interview, how to start working, what kind of careers are you interested in. And then let's say that after high school, they get a job, but then they become 26 and they decide, hey, I want to go back to school and I need some help. They can open a new case then with OVR and come back. And then they might stop school. And then at age 40, they might need to get retention services and they come back. So we are here throughout somebody's lifetime, and you can have multiple cases with us. So OVR is a process. I always tell people, you know, if you are looking to open an OVR case, it does take some time. It has become a lot quicker than it used to be in the past. We are definitely looking for rapid engagement, which means that from the time you call to make a referral, the OVR counselor needs to contact you within 5 days of that referral. So that means we set up an intake, we get things started, and then from there, there's also the process. So like I said, 5 days to application. Once I meet with you, I have 60 days to find you eligible. This can be a lot quicker than 60 days. So when I call somebody to do an intake for OVR, I usually ask them to bring records. A lot of individuals already have records in place. They might have an IEP, or they might have something from their doctor. If you're involved in, you know, a Geisinger system or a Commonwealth Health, you have an app that usually has your disability right in the health section, summary section, and I can use that to get you eligible. So 60 days is typically for somebody who had no records and needs to get testing, or we need to send out for records. But, you know, if you bring records with you, we can get you eligible a lot quicker. From there, once we get you eligible, we meet again to create a plan. That plan, there's a 90-day window. Again, that typically doesn't take 90 days, but it can take up to 90 days. And we meet and discuss what we're going to work on a plan. And that's where the OVR services come into play. I usually tell people from start to finish is about a 2-year process. Not to get you open, just 2 years from the start of you calling till you're employed and all your services are complete and you are working competitively and it's successful. So I always give that kind of time frame. Some people it's a lot quicker, and some people do take a little bit longer with their services and need a longer amount of time than 2 years. Okay, so during your application process, it's all about the individual. I'm trying to gather as much information as possible to really determine what kind of services this person would need to be successful in working. So we really talk about an individual's disability. What is their disability and how does it affect them? And some people that I work with have never worked before. So I always give scenarios of how does it affect them in the home, how does it affect them in the community, or sometimes in the school setting. And then what kind of support services do they have at school? I have individuals that need some behavior support in school. I have individuals that need behavior support or support coordination. I need people that need OT or PT, and just kind of what services they get in school. And then what is their school performance? So we want everybody to be successful in high school, and graduate high school. Some individuals need to go back and get their GED. So we help individuals with their GED. I do see that somebody did ask, is OVR services only in PA? OVR is what we call it in Pennsylvania. We are with the, we're a federally funded program, so most states have a vocational rehab type program in their state. So OVR here is Pennsylvania, but every state has a vocational rehab program. So back to the application, we talk about the individual's interests, their hobbies, their activities. So what do they like? What do they do well in school? Do they like math or reading? Some people like social sciences, and we kind of look at that. And then do they have any work, and have they ever done any volunteer experiences? I do talk a lot about volunteering with my individuals. So my caseload has a lot of individuals with intellectual disabilities. So we find volunteer is a good starting point sometimes to get them used to going to a schedule and following directions. So true or false, can anyone receive OVR services? That is false. You need to have an impediment to working to receive OVR services. So I did say, I do feel that most people do have a qualifying factors to receive OVR services. So diagnostic services and vocational evaluation. As I said in the beginning, you need to become eligible with OVR. Doing this, you might already have medical records or psychological records or neuropsych or audiological or psychiatrist records. If you don't have any of those, OVR can send you for testing. Vocational evaluation, we determine a customer's potential. So we really can go and do that. Somebody asked multiple cases with OVR. There isn't a limit, correct? So no, there is not a limit with OVR services. You can keep coming back throughout your life if you need help. And then is it best to get started with their child supports coordinator? So you could get started anyway with OVR. We get referrals from supports coordination, and sometimes I help individuals get started with supports coordination. So it works both ways. Again, any age kind of starting from 14 up, and if you need help with working. Sorry, I lost. Okay. Counseling and guidance. So this is the big thing we provide with OVR. So OVR is counseling and guidance. A lot of times I sit with individuals and we explore their abilities. We learn successful work habits. We talk about setting job goals. So especially with students in high school, they're unsure what they want to do after high school. They're not sure what interests them. So we do a lot of interest surveys. I meet with my individuals in the summer a lot to go over what they're interested in. I actually have a little booklet that they fill out with their interest and what subjects they do well in school. And then from there, it leads me to the next step of what career path they'd be interested in. And it just opens that conversation of where do we go to next. Another service that we provide is restoration services. So this category, we do medical services and equipment to help people work and be independent. So like I said, we are very individualized. We can help with hearing aids. We can help with physical therapy. We can help with smart pens. We can help with computers or iPads. It really depends on the individual. So sometimes I work with individuals that are quadriplegics and need a whole restoration services. They need modifications to their cars or their home, in their workplace to make them successful in the workplace, and the equipment will help them. So we send them for evaluations to kind of look and see what would be the best that would help them, and then OVR can help pay for those. Vehicle modifications I kind of touched upon. We work with people that have amputations, like I said, paraplegics, quadriplegics, and some people need vehicle modifications. And so OVR can help with those vehicle modifications to really get somebody to and from work if they need. Training services is another service we provide. So I have a lot of high school students that go into the college setting after high school. And so one of my things that I talk to the students about is post-secondary education. Which colleges are they interested in? Have they gone on a tour? Have they thought about what they want to study at these colleges? And sometimes we can help with funding for them to go to college. So funding changes every year. We don't know the amount until July. Some years it's been $14,000 and other years it's been $4,000. And there are qualifying factors for us to help you with funding towards college. I usually tell individuals going to post-secondary education that if they're looking for a college in Pennsylvania, OVR is typically already a provider. They're a provider with OVR, so that we're already established with them. We are also established with college outside of Pennsylvania. I have students that attend the University of Richmond. I have individuals that attend Ithaca. So we can make a college a provider of OVR if they're willing to. So if a college is willing to, we make them a provider and we work with the college. Those individuals in college work with OVR. Every semester I get their transcripts. We go over their grades together. We kind of see if they're struggling in any classes and how we can help. We get their schedule at the beginning of every semester to really see, you know, what are they taking? Are they full-time? So to be eligible for funding, you do have to be a full-time student in post-secondary education. And then once a semester, I check in if I don't hear from the student. So some students, they call me regularly and we really talk about tutoring and talking to the professors and being a self-advocate. Like, how do I advocate for myself while I'm in college, away, you know, some are dorming or away from their families. And I'm just like a little added support for them to make them successful. So they'll call me maybe 2-3 times a month, where other students really are doing well. And I just kind of check in quarterly to make sure that everything's going the way they need to be going. Another service we provide is placement services. So placement services is writing a resume, looking at job leads. So we have what's called the business service representative at OVR. And her job is to go out and meet with different employers to really get a good understanding of what OVR does. And then they will send our business service representative open positions within their company. So then I can send that to our individuals. I have some individuals that need to work from home just due to their limitations or their impediment. I have some individuals that need to be sitting all day. I have some individuals that can't walk far distances or can't lift. So these job leads really help me determine if this is a good fit for the customers I work with. I can help people fill out applications. So I always tell people if they're stuck, call me and I can walk through with them how to fill out an application. I can help them, especially with government applications. They're a little tricky sometimes. So I have people that sit with me. I have one girl right now that is looking to attend phlebotomy school in a very specialized program, and she doesn't have a lot of support. So me and her are going to sit together and fill out that application together, just to kind of see, you know, what she needs improvement on when we're doing the application, and it's a good training session. And then interviews. So I can do a mock interview with somebody else in our office can do a mock interview to really go over, you know, questions that might be asked on an interview, some questions that the customer can ask the employer, and just to kind of help them so that they feel a little more confident in their interviewing skills. So what do you need to get OVR started? There's a few ways. You can go online to the career link and fill out the referral online. You can call our office. The number is right there, the 570-826-2011. Now, this is for the Wilkes-Barre office number, which does cover the 12 Northeast counties in Pennsylvania, but OVR has offices throughout the state. So you can just look on the PA career link, or you can Google PA OVR, and you can find the appropriate office for you. And I know somebody asked about other states. As I said, you could probably Google vocational rehab if you're in New York, vocational rehab in New York, Virginia, and they should come up with who you can contact to make a referral. You'll need a photo ID. If you don't have a photo ID, we could take a school ID, or a birth certificate and a social security card also count. We need an individual's social security number, and then name and addresses of any doctors, counselors, or agencies that they work with. I also ask for medications because sometimes medications interfere with working, so I do like a list of medications so that I have a better understanding of what they might need in the workforce. And then if somebody is under the age of 18, a parent or guardian will need to be there to sign the application. I do like the individual to be there. So if they're under 18, the parent and the customer would be at that initial meeting. So entitlement versus eligibility. So services provided during high school to be successful. So these are entitlement services. School identifies students in need of accommodations. School will conduct assessments or evaluations, and school schedule IEP meetings, and school will involve the parents or the guardians. Eligibility. Services you will need to ask for and meet criteria for after high school to be successful. You are responsible for asking for accommodation and requesting services. So I always really try to tell individuals, when you're in a working environment and you need an accommodation, every employer has forms for accommodations or a way to fill out to receive accommodations. So I kind of talked about in the beginning those restoration services and equipment. So a lot of times I will recommend the customer to first go to their employer and ask for accommodations and see if they can get the accommodation through the employer. And then if not, then OVR can sometimes pick up the cost of the accommodation. So we always try to first go through the employer. And then you are responsible for requesting and scheduling assessments and evaluations. So again, OVR can pay for somebody to be evaluated. But sometimes people need mental health evaluations, so we can refer you to mental health providers. And then we always encourage the person to schedule their appointment and keep those appointments. And those services, once somebody's 18, will not always involve the parent or the guardian. The same thing with OVR when they're 18 is I need a signed release on file to talk to a parent or a guardian. And then we have high school versus post-secondary training. So high school, there's no cost. Attendance is checked. There are 30 or less students. Your books are provided, and teachers often use the board. Where the difference is when you go to college or a training program, you pay, attendance is not always checked. There can be up to 100 plus students in the room. Books can cost a lot, and professors may just talk. So what's really in it for you? The working and the independence. What are some things I can now do to prepare for my job goals? I'm not sure if I lost you. I have you on the phone still.
We can hear you.
Okay, wonderful. Did you guys lose my PowerPoint?
Yes. Lori, we can't hear you, but we can see the PowerPoint.
Now, can you hear me?
Yes, yes. Perfect.
Wonderful. I don't know if the internet just went out, so I do apologize for that. Okay. Nope.
So Lori, we didn't hear what you said about what they can do now to
Yeah,
prepare.
wonderful one. Okay. So what people can do now to prepare for their job goals is that individuals can really look at writing a resume, having a resume ready, and seeing their past job experiences. They can make sure they put all their schooling on there. They can work on their interviewing skills. So they can practice, they can look up, especially I always tell people, go online and look up good questions to ask during an interview. And then you answer those questions so that you know what the answers are, as well as what they're looking for an employer. Every PA Career Link has a resume builder as well as an interest scale. So you could go on PA Career Link and kind of look at what interests you and what jobs are open. There's also another website called ONET, which is ONET. You can go on there and really start searching interests that you have. And then under that, they come up with the different occupations that you can do. So if you looked up dental assistant, then it will tell you under dental assistant what you need to become a dental assistant, what the qualifications are, how much you would make. So it's a good resource, I tell, especially for somebody that is unsure what they want to do and what career path they're looking for. So those are kind of things to get, started. If you have that impediment, I always tell people call OVR. So my PowerPoint, that was kind of the last slide, but I did want to go into some changes that have happened recently with OVR. And then I think I have time still for questions and answers. So OVR, we are federally funded. We are under Commonwealth of Pennsylvania and employed by the Commonwealth of Pennsylvania. Our order of selection recently has closed. What that means is that when I talked about that eligibility, you are placed in an order of selection. So we have most significantly disabled, and non-disabled, significantly disabled. And we right now are taking individuals that qualify in that MSD category, that most significantly disabled. So that means that you would come to us, we would do the referral, we would do the intake, and then we'd get you eligible and see which criteria you fell under. If you don't fall under the MSD category, you will be put on a wait list. And I tell people to still do this because the wait list will continually open up, and it might go in the order that you're placed on the wait list. And we're unsure how long the wait list will last. But if you fall under the MSD category, the most significantly disabled, then we could get started. And this is based on, there's a few criteria: communication, mobility, self-direction, work skills, work tolerance. So it's all based on those categories of what you would fall into. So that is new, and that just started April 1st. And then starting July 1st, the most significantly disabled category, or the MSD, will actually have another criteria to be put into it. So right now you need 3 limitations. As of July, you're going to need 4 limitations to be placed into that category. So those are some of the changes that are happening right now, and that's just due to funding and money and that kind of stuff, and just making sure we can serve the people that are open with us right now, and that to get people started in the services. So go ahead.
Thanks so much, Lori. We actually do have a few questions that came through while you were presenting. So someone asked, do you offer translators? They said that they have 2 deaf grandchildren. One of their grandsons is deaf and has epilepsy. They would need a sign language interpreter for the intake.
Yes, we do. We have one vocational rehab counselor who is fluent in sign language. So that is very helpful for us, but we also have interpreters that we work with.
All right, thank you. Another person asked, would support ever include a person one-on-one to be with a person at work?
Yes. So that is one of the services we do provide. It's called job coaching. So a job coach can start off with somebody and be with them their first 40 hours. And then after that, it typically fades off. Now, not everybody is able to be faded off with the job coaching. So my caseload, for example, is I do work with a lot of support coordination agencies. And so I need to work with the support coordinator to make sure that I can provide the services full-time for 3 months, and then the support coordinator can pick it up after OVR is done. So OVR services are for 90 days when somebody's working, and then typically support coordination can continue those services. After 90 days, and if they're not involved with support coordination, we kind of need to come up with a plan of what we would do.
Okay, thank you. Another question. Could you please explain the pre-ETS program and what it entails?
Yeah, so pre-ETS program is for anybody in high school under the age of 22. Pre-ETS is typically starting at age 14. I kind of touched upon that. And when they're about 14 to 16, I would say, we do a lot of groups in the high school. Those groups are just talking about job exploration, post-secondary training, self-advocacy. And then when they become about a junior or senior, we could do a paid work experience. We could do a job shadow, driver's training. So if that somebody is going to leave the workforce and leave high school and go right into the workforce, and they don't drive yet and they need some extra driving lessons, we can help them get their driver's license. So pre-ETS are kind of those services we provide to individuals in the high school setting.
Thanks, Lori. Some more questions here. How is a smart pen different from a regular pen?
Sure, a smart pen can record the sessions. So if somebody's in classes in college, it can actually record the lessons and the instructor. Sometimes a smart pen too has these tablets that when they're writing on it, it can connect to their computer so that their notes can be uploaded right into the computer. It really depends on the smart pen and what we're looking for, but it's there to support somebody. I provide them to a lot of post-secondary education students, but sometimes in the workforce, if somebody has a hard time like with processing and they need to take notes in like a training like this, the smart pen can come in helpful where they're just writing on a notepad and it can be uploaded to their computer.
Awesome, thank you.
Mm-hmm.
Okay, some more questions. So are the changes that you mentioned, is it due to changes in federal funding and freezes?
It is. So this year we are flat funded, which we haven't been flat funded in a few years, which we did lose a significant amount of money versus other years. So we're just kind of making sure that we can serve all the people that we have open, as well as those that are in that most significantly disabled category right now. And again, each year funding changes. So we won't know we believe next year's funding will also be flat funding, but then we don't know what will happen after that.
Okay, and that goes a little bit into this next question. Could you go over the 3 limitations that individuals have to qualify for the MSD category? You had mentioned that there will be another one added in July.
Correct, yes. So right now, the categories are mobility. Do they have any limitations in mobility? Self-direction. Do they have any limitation in self-direction, which is like problem solving? Do they need help getting ready? Self-care, communication, work skills, work tolerance. So for example, individuals with epilepsy, my niece has epilepsy, and if she gets overstimulated by lights, it can cause a seizure very easily. So that would be a limitation. That work tolerance, that would be. So we need 3 of those. So it's self-direction, communication, work tolerance, work skills. So 3 of those. And then in July, you need 4.
Okay. Could you remind people how they can find an office that's near them?
Sure. So you could Google Pennsylvania Office of Vocational Rehab, and that will come right up. I will share, and I can send out like a brochure, which the back has all the different, I don't know if you can kind of see it, but I'm on blur. But it has all the different locations and regions and who to contact if you live in that region. So like we have an Allentown office, an Altoona, Du Bois, Erie, Harrisburg, Johnstown, Newcastle, Norristown, Philadelphia, Pittsburgh, Reading, Washington, Wilkes-Barre, York, and then our central office in Harrisburg.
Okay, great. Yeah, if you email that to me, I can email it to everyone. That'd be great. Okay, do we have any more questions? Just put them in chat. I think we are caught up with all the questions. So if you do have any other questions, please place them in chat. This one came through before. If you can remind everyone what age group qualifies for services.
Oh, so 14 up. So starting at 14, you qualify. And I think right now my oldest individual is 88. So she needs hearing aids. She still works full time at the area of aging. So hearing aids and working. So that qualifies you.
Wow. That's pretty amazing.
Yeah.
Another
So we
question.
do help funding, we do help funding with hearing aids. And I always bring that up because like this individual, she works and she doesn't make a lot. It's just, she loves going there. And hearing aids are very expensive. So OVR can help with that funding of hearing aids.
Wonderful. Okay. Can a hospital social worker directly refer a patient or patient's family, or does the patient's family or the patient themselves have to do it?
No, anybody can refer to OVR. So it could be hospitals, it could be family friends. Anybody can refer somebody to OVR. They just need their basic information, name, date of birth, address, phone number, and from there we can kind of get the rest of the information.
Someone asked if you could repeat the MDS categories and if you would be able to send a list of the how to qualify, the list of qualifiers.
Yes, I'm going, and I'm pretty sure I have them all at the top of my head, but I will send a list out too so that you guys know exactly what would qualify somebody. But like I said, communication is 1, self-direction is 2, mobility is 3, work tolerance 4, work skills 5, missing something in there, but I think there's 6 of them. But yeah, you have to have 3 of those right now in July 4. But I'll send a list along with the brochure so that you guys can see exactly what impediments would be, and that would qualify you.
Thanks, Lori. Can you assist, hold on, can you assist with mobility devices if needed? Mobility meaning wheelchair or walker?
Yeah. So for when I say mobility issues, that could be somebody can't walk 100 feet. It's not just wheelchair. But yes, we can help with walkers, wheelchairs. Right now, I think I'm ordering a rotator walker for somebody. So they just need to qualify for us. They need to be working, and a doctor script is all I need to tell me. And then we use a provider. So right now, I think this person's using Andrew Brown. We're getting their appropriate walker for them so that they can continue working, and then their case will close. And if they need something in the future, they come back.
Okay, great. Can OVR assist on maintaining a current position at work if a new diagnosis occurs while employed that requires accommodations?
Absolutely. So I believe, and again, April 1st, everything changed. So I'm still kind of getting it all in my head too. April 1st, our categories changed, but I believe that job retention is still going to remain open. So if somebody is in immediate need to keep their job, they can open with OVR and be open. So if you have a new diagnosis that is really affecting you or something that came about, yes, we can open and help.
Okay, last call for questions. Okay, here's another one. Do you inform the high school nurses? Hold on, I have to make my screen bigger here. Let's see. Do you inform the high school nurses? I'm thinking of a high school student. Okay, that was it. Do you inform the high school nurses? I'm thinking of a high school student.
So each of us work with different school districts. For example, I am in the Back Mountain area of Pennsylvania. So Dallas and Lehman School District are my school districts that I work with. And my goal is to work with everybody at the school as much as they let me. So I talk to teachers, I talk to the principal, I talk to guidance, anybody that's willing to hear about OVR and what we provide, I really try to inform them. I have actually never talked to the school nurses, but I appreciate that suggestion because I never thought of it. And they might be a great referral source too. And they might know people that can use our help. So that's a great suggestion. Thank you.
Great. Can someone have a one-on-one nurse and still work?
Yes, definitely. So I know that sometimes individuals have a lot of medical needs and they need that nursing support with them. So yes, I have had individuals with a nurse and work. We have to find the right employer that's kind of good with that whole scenario, but they are out there and we'll help find that.
Awesome. Hey. Well, thank you so much, Lori, for that fantastic presentation. We really appreciate all your knowledge. I think everyone learned a lot tonight about OVR. And yeah, if you send me the information, I'll make sure to send it out to everybody. We are going to take a break. We will be back at 7:05 for our next presentation. So I will put that up on the screen as a visual reminder. Again, thank you so much, Lori.
Thank you for having me.
Okay, so we are going to continue. So hopefully everyone can return back onto their screen. Okay, so our next presentation is Transitions in Care from Pediatric to Adult Epilepsy Practice. We have some awesome speakers for you guys tonight. Sarah Stoney, Adam Greenberg, Dr. Bethany Thomas, and Diego Rojas will present for us. So let me stop share and they can take it away.
All right, excellent. Thank you. My name is Adam Greenberg. I'm a nurse practitioner at the Children's Hospital of Philadelphia, and tonight I will be presenting with Sarah Stoney, MSW social worker at Children's Hospital Bethany, Dr. Bethany Thomas, nurse practitioner at uh, Penn Medicine, and Diego Rojas, who is a former patient and is going to talk a little bit more about his experience moving from pediatric to adult care. And if you can give me one moment here, I will share our slides. Okay, can everyone see these slides?
Yes.
Excellent. Okay, great. Well, we'll get started then. So first, thank you, Laurie, for your presentation. That was really wonderful. Hearing more about OVR, I took some notes myself. And thank you for having us again. And I do want to start off by saying that we know that this discussion about moving from pediatric to adult care can produce a lot of anxiety when we start thinking about that. And so, really, our goal here tonight is, in as much as we can, to sort of talk about what the process looks like, and hopefully maybe ease some of that anxiety. But of course, acknowledging that everyone's a process might look a little bit different. So, with that said, in terms of our specific goals for the next half hour, I'm just going to provide you with some general transition information. Sarah Stoney is going to provide you with the perspective, the pediatric perspective, and then Dr. Thomas is going to be talking about assimilating into adult epilepsy practices, and then we will have Diego present after that. So, healthcare transitions. So when we talk about this, um, we talk about basically it's the purposeful, planned movement of adolescents and young adults with chronic physical and medical conditions from child to adult oriented care. And this is really one of many transitions that happens in young adulthood. We can think about going from high school to college or high school to employment, moving with parents to moving out on your own, potentially going from high school to, going off to college. So one of many transitions. And for our young adults, we like to think of this as a movement from dependence to interdependence, meaning that, where at one point maybe the caregiver was really the care manager, now moving from care manager to consultant, and the young adults really sort of the person now in charge of their care and is working with their family and their community to help with any decision making. And then just quickly, healthcare transfer is the movement of clinical care from one provider to another, and this is sort of a point in time. And we'll touch on both of these. So, why do we transition? I mean, that's a question that comes off pretty frequently. And there are a few reasons, right? So, we think about it from the patient perspective. We need to make sure that our young adult patients are getting the appropriate clinical care. The way we sometimes think about it is adult trained eyes need to see these adult patients to think about chronic diseases, to think about reproductive health, where we know the strength lies with adult providers, maybe perhaps a little bit more than our pediatric providers. And really, we need to make sure for our providers too that they are working within their scope. That meaning that they're trained to work with kids and adolescents, and we need them to continue to do that. We also have to continue to have our adult partners really master the skills of caring for our young adults. Another reason too is really about just the evolution of medicine itself and access. Really, what I just want to highlight on this slide is in particular sickle cell disease, because I think it's a really good example of how advances in medicine and increases in life expectancy have changed how we deliver care. So maybe even a generation ago, life expectancy wasn't what it is today, but thankfully we've seen it now to go 50 or close to even to 60. But really, what that means is that a generation ago, adult hospitals really weren't anticipating as many young adult patients as there are now, which of course we want to see, right? And so right now there are a lot of young adults that are turning 18 and need to move into adult care. And even at the bottom right, I just wanted to show you just at Children's Hospital, where I work, just sort of what those numbers look like. So you can just see that if this is for patients that are over 22, last year, specialty care saw maybe about 14,000 visits. And the way we think about that sometimes is access. We need to make sure that we can still keep our spaces open too for our pediatric and adolescent patients. So, how do we do this? The really great thing is that over the past, I'd say 15 years now, there's been a lot of research into the best way to help move pediatric patients from a pediatric system of care to an adult system of care. And sort of probably one of the most well known, at least in the work that I do, is from a group called Got Transition. And I put their website there on the bottom right if you wanted to go there. But they're under the Maternal Child Health Bureau. And really, they have set out, or what they call the 6 elements, really of a good transition, starting with, having a policy. And really what we mean by that is that your pediatric providers are discussing with you sort of at what age we start thinking about the different steps that move us to adulthood. And that can include things like Lori was talking about, it, like at 14, reaching out to OVR if you're thinking about employment, but also sort of at what age is the most appropriate to have transferred your adult care to. And we can have those discussions as early as 12 to 14. Of course, we think about tracking and monitoring, and that's just making sure that we're addressing all of our needs as patients as they get older. There are readiness assessments out there, which their aim is to really develop, well, first identify skill sets that our adolescents might need to build and then help them work towards that. A very specific example is medication management. Does our patient know how to order a refill? Do they know where to store it? Things like that. And then, of course, we sort of move along to actual planning, sort of what providers a patient might see, the transfer of care of itself, which is making those appointments, and then transfer completion, which is really on our pediatric side. Sort of, are we checking in after a patient has seen adult care to ensure that that has gone as smoothly as possible? So these are very broad ways of looking at it. Again, these are designed to give clinical practices some scaffolding on how to approach this, and it might look different for everyone depending on where you access care. But just wanted to share that there is a lot of work behind how we approach this. So with that, I'm going to turn this over to Sarah, just to talk about sort of what are the guidelines, at least the CHOP, and then really her approach for this.
Thank you so much, Adam, and thank you, Rena, and to the Epilepsy Foundation for having us today. I have the pleasure of working with Dr. Thomas over at Penn, who is such an amazing transition partner, as well as Adam, who's a part of our developing our specific epilepsy guidelines. So happy to share that information with you today. Feel free to put questions in the chat as they come up for you, so that we can get to them at the end. So with that being said, what are the guidelines for transition? And the reality is that we know that no two transitions ever look alike. So we know that timing may vary by the provider, by the department, and by the institution. Additionally, oftentimes we like to transition at times when we feel is most appropriate for the patient themselves. So we may choose when when their seizures are very stable, or and choose not to transition at a time when perhaps we're making medication changes, so that we can ensure that patients are as stable as possible during the transfer process. We know that inpatient and outpatient transition rules may differ. A lot of the motivation for CHOP to ensure that we have safe transitions is to ensure that our inpatient providers are taking care of our pediatric patients, and that adult providers are taking care of our adult patients. We know that chart access, consent laws, and policies, which we'll talk about later on, all vary with age. At CHOP, after 12 years old, parents start to have limited access to parts of the chart. There's additional limited access at age 14, and then more limited access to at age 18 as well. And you and your family can work with our providers to ensure that the timeline that is put together for you is the timeline that will work. Feel free to go on the next screen, Adam. Awesome. So I'm going to talk a little bit about the program that we developed at CHOP to show you our framework, but also to give you ideas about conversations that you should be having with your providers now. Over the last 10 years, the transition teams at both CHOP and Penn have done a lot of needs assessments to assess what the outstanding issues are and what our partners need in order to have a successful transition. Our adult providers explained that they need they need their patients to have a clear expectation of what adult medicine looks like. Adult and pediatric medicine oftentimes looks very different. Even in speaking visually, even the buildings themselves look different. So really ensuring that our patients are well aware of what's going to be different in adult care. They also will succeed best with clear, concise summaries of the patients that they're receiving. Our pediatric providers really need someone to help own the transition process. So they need someone who can facilitate the transition, ensure that they know about insurance barriers, resources that are available for our pediatric patients, as well as being informed about the transition process itself, any barriers or any limits that are preventing the transition from happening. And then from our patients and families, we know that they're looking for convenient access to care. And it's going to take not just convenience, but also a trustworthy provider to ensure that their transition is going to be successful. Next slide. So when we took these three groups of needs into consideration, we developed a transition clinic, which is led by myself, specifically for our epilepsy population. So this allows me to have one-on-one time with our young teenagers and young adults with epilepsy who are going through the transition process. Those individuals can have their parents with them if they'd like, or they can meet with me individually. Next slide. So in this one-on-one visit, the visit lasts about 45 minutes. It's a video visit. And in this process, we do a thorough social work assessment. And part of the reasons why we do that is because not every person with epilepsy in pediatric care has necessarily met with a social worker before. Epilepsy is very common, as we know, and you may not have had any need to talk to a social worker before. However, in my assessment, I may be able to assess whether or not there's any community resources or other supports that I can help put in place for you prior to transition to help you succeed in the adult world. The second part of the visit is really about education. We reiterate why the transition is important. We will address your transition readiness. And while we're also assessing, as Adam said, we're also going to address what your actual function and limitations are. We all know, and we'll talk in a minute about what happens when you turn 18, but we all know that we don't go to bed on the eve of our 18th birthday and wake up like a fully functioning adult. So we know that we may need help in certain areas. So identifying those support people is really important for a successful transition. Debunking myths and decreasing anxiety, I think, is some of the number one things that I think is the number one goal out of the transition time that I spend with my patients. Just debunking myths as to that there's going to be gaps in care, or that people are not going to have access to any neurologist, or learning about where to park or where to navigate a new building. Just eliminating some of those very normal expected anxieties about the transition process can be extremely helpful. We talk about what's going to be different in the adult neurology world, and then also what to expect during your first office visit, explaining that, even though your adult provider is going to have all of your medical information, it's going to be really important for you to answer questions and for you to tell your own story in your own words. You'll also learn what will change and what will stay the same, and what supports are going to be different in your adult neurology practice. Next slide. So why is the education piece important? Well, as I just mentioned, our teenagers become legal adults at age 18. So this changes parents' access to their medical records as well as many other legal changes. You're also going to be asked new questions and likely hear new terms that you may not be familiar with. Things such as advanced directives or living wills is something that regularly gets asked in adult medicine, and we want to make sure that you know what those things are. We want to make sure that you also have access to resources for planning for school, work, and your mental health. We have the luxury in pediatric care to have social workers at institutions like CHOP who may be able to readily get you set up with resources that may not be available to you in the adult world. We also have the opportunity for us for you to assess your own transition readiness. And again, identifying those people that can help you learn more about how to manage your healthcare needs, while also identifying the people that can help you with things that you're not able to do for yourself. Next slide. So the legal changes at age 18. While I say you do not wake up a fully functional adult, there are a lot of legal changes that happen at age 18. So officially at age 18, you know that you are a legal adult. So if you're a CHOP patient, your parents will lose access to your MyChop account and likely other patient portals across different health systems. But you are the one calling the shots. As I often describe it to people, I think about it as that you're on a ship, and for the first 18 years your parents are steering the ship, and then at age 18 you take over the wheel and you start steering. um, your sharing the medical information will change. You get to determine who has access to your medical information. So again, it's not to say that your parents can't help you or that people in your life that do support you can't have access to your medical information, but just like you're steering the ship, you get to determine, yes, this is an appointment that I want my parents to sit in on, or no, I'd like to have privacy. You'll also hear terms like advanced directives. Or living wills, which are just new terms that you'll be asked when you're in adult appointments. Next slide. So advanced directives are legal documents that allow you to plan and make your wishes known in the event that you're unable to speak for yourself. So advanced directives consist of a living will and a medical or healthcare power of attorney. I like the resource 5 Wishes. It is a legal advanced directive in most states. 5wishes.org is a website where you can actually purchase 5 Wishes, and it goes through 5 different sections of an advanced directive, and quite frankly, a little bit more. What I appreciate about tools like this is that it allows you to think of things a little bit more outside the box. Advanced directives is not just something that we talk about for patients that have chronic illnesses. It's also something that anyone can have. So if you have specific wishes that you want carried out in the event that you can't care for yourself, it's important that you tell someone and perhaps also have an advanced directive outlining those wishes. Next slide.
Sorry.
That's okay. All right, and we're also going to plan for all life's other transitions. So planning for school is a huge thing that we're going to talk about. Major universities and colleges are required to provide you those reasonable accommodations as they're related to your neurologic condition. However, you need to do this by partnering with your healthcare provider. It'll be up to you to disclose your needs to the school, usually through the Office of Persons with Disabilities. And they will either have forms for your healthcare provider to fill out, or they'll accept a letter from your healthcare provider explaining what those needs are. Next slide. And then you will join the workforce, and that support really should continue. Lori's presentation on OVR really talked about how you can be supported in the workplace and that there are organizations that can provide you and assist with the accommodations that you need. It is a workplace responsibility to provide those accommodations to you. You do need to work with human resources and have the conversation about what it is you need to be successful at your job. Next slide. With regards to other life transitions are, of course, all of the other medical and behavioral health transitions that you'll likely go through at age 18. And one of the ones I'd like to address specifically are mental health considerations. If you're seeing a psychologist or a psychiatrist that only treats children, it's going to be very important that you have a transition plan to transition to adult providers. And part of the reasons why this is so important is because we have a lot of mental health crises going on in the United States, and that providers are very overwhelmed. And you may even have your own personal experience of trying to find a provider near you and getting hit with a lot of wait lists or not really being able to find somebody who's able to meet your needs. So being proactive and ensuring that you have access to these providers once you turn 18 is so much more important. Additionally, psychiatry and psychology are much more separated from neurology in an adult setting. So, as a pediatric patient, your neurologist may have been more comfortable prescribing psychiatric medications. And in the adult world, that's going to be much more separated. So, it'll be even more important that you talk about what your psychiatry plan is for when you transition. You can call the back of your insurance card to get a list of in-network providers for both psychologists and psychiatrists, or you can get a referral from the person you're seeing, or I also recommend people talking to their primary care physician. Next slide. Tips on managing your medical needs as an adult. I always say the system that works, emphasis on works, for you is your system. So if you're a person that really relies on technology, utilize that to your advantage. I always talk with patients about how they remember to take their medications. The next question I ask is, how often do you forget to take your medications? Because if there is a gap between what your plan is and then how it's actually being executed, then that tells you, you know what, I need a new plan or I need more assistance. So if you're a technology person, definitely utilize technology to your advantage. There are ways to set up your medical ID on both iPhone and Android, available on the website that Adam talked about, gottransition.org. The graphic on the right is the example of what that looks like. It can be helpful to just keep a health section of your phone on your phone, whether it's in the notes tab, or keep a card in your wallet with your medications and conditions in the case of a health event. As a non-medical person, I can barely pronounce a lot of my own medications. So I also keep a list on my phone so that when I go to the doctor, I know that all of my information that I'm sharing with them is completely accurate. You can also use apps to track symptoms or to remind you to take medications and ensure that your emergency contacts are updated in your phone in the event of an emergency and somebody would need to contact your loved ones. Next slide. I think we're now moving on to Dr. Thomas, who's going to be talking about what all of this looks like on the adult side of things. Thank you so much.
Thank you, Sarah, and thank you, Adam. So I'm here to talk mostly about the transfer part. And so in my role as a nurse practitioner in an adult epilepsy clinic, I help to catch a lot of the transitions. And so as they're coming into adult care, I help to streamline that process as best as I can. And I've done a lot of work alongside Adam and Sarah to really see kind of what the issues are and identify which parts of that we're able to fix or address, and really how best to work within the healthcare system that we have. And so for my piece, I kind of broke this talk down into kind of how we can work through different stages of the transition during the office visits. And so big question is, how do you learn to adult, and how do you kind of embrace those changes that we know are coming? And a lot of this starts very early, as Adam discussed and as Sarah kind of carried through. A lot of this will go the best way possible the more prepared you are. And so it starts much, much earlier than really people expect or plan for. And so on the pediatric side, your pediatrician can help you to take on more responsibility in your own care and set goals for your knowledge. And it's really important for these parts to happen in the pediatric setting, because that's really where you're comfortable. It's very hard to come to a new provider and then start to learn these skills, which do take practice. So over on the pediatric side, while you're with a provider that you've known for a long time, things that you can do are to start speaking up, to start spending some time during each of these visits, potentially without your parents. And for parents, this is also a big change for you and something to shift in your mindset as well, and is much more comfortable to do on the pediatric side, again, with a provider that you're comfortable with. Important and helpful to keep a folder with medical information and papers, and then starting to learn how to schedule appointments, fill prescriptions. Like Sarah just reviewed, all of those apps and technology things that we have at our hands now make a lot of this much more easy for patients to do. Parents and caregivers can encourage patients to take on more responsibility and help practice explaining both the diagnosis and the medical history, and then provide opportunities to work on transition goals. So maybe take turns scheduling appointments, listen in. Those things can be very intimidating for somebody when first starting out. Also learning how to call in own refills or manage those type of things. The sooner that you feel comfortable doing that and the more independence that you can take on, the better that will feel in the long term. Adam, next slide, please. And so for a medical transition plan, the first question, or one of the first questions should be, where should you go? And just like Sarah mentioned, it's important to acknowledge kind of all of the different healthcare providers you need. So asking your pediatric neurologist, not only do you still need to see neurology, but what kind of neurology do you need to see? Because not every person with epilepsy needs to see an epilepsy specialist. Some people will be very well served by a general neurologist. And so for some folks, their priorities might be to see a provider that's closer to them. For some folks, they might need to travel further to see a neurologist with a specific area of interest. And so those are things that are important to discuss with your current pediatric provider, so you have some guidance in where you should be going. The next question, once you have that appointment established, is what you should bring. And so you really should never go into an initial appointment with an adult provider expecting them to have anything. So certainly a lot of the work that we do is trying to make sure that we have records ahead of time, or make sure that we have summaries sent over ahead of time. But this is definitely not a guarantee, and I would say happens in the minority of times and not the majority. And so you should be prepared to go into your first visit with all of your medical records, or at least the pertinent ones, including your office visit notes, labs, imaging reports, or any brain imaging specifically that you've had. You really want to get those on disk so your adult provider has access to those. Other things that you should think about are all of those other slides that Sarah went over. Things that you want to think about for work and school transitions and a life transition plan, and really starting to have those things in place before you're making the shift at age 18. Next slide. Healthcare changes, there are a lot of them at 18. I won't spend a lot of time here because Sarah went over a lot of this, but legally, when you turn 18, you are in charge of your own health care. And so the medical team will be looking at you independently to schedule appointments, manage medications, reaching out to us to discuss any kind of new or different medical issues. And legally, if there aren't very clear instructions within your chart, we aren't really allowed to talk about those things with any other member of your family without your clearance for that. And so a lot of people, because on the pediatric side, they have not familiarized themselves with communicating with their care team. And so then they come over here and mom's calling us on the weekend because something happened. And sometimes the provider really is not allowed to have that conversation if that's not clearly established. So again, those legal changes really do impact your healthcare and the way that you manage those. So you just want to think ahead and have a plan for those things well in advance. Next slide. And so for the first adult visit, I like to spend some time really just talking about this because this sets kind of the feel both for the provider and the patient for establishing that relationship. And that first visit is really important, and obviously on the patient side, for you to feel comfortable with the care that you're going to be receiving into adulthood. And it can, I've had experiences where it goes really, really sour. And for reasons reasons that could have been prevented. The number one thing that happens is people are very late and then don't get the full amount of time for their visit. And so some of these like very simple logistic things, I can't stress enough. Just knowing kind of where you're going for the adult appointment, knowing who it is that you're seeing, making sure that you've had that registered, making sure that all of those kind of expectations are set. And then Sarah discussed some of the very basic logistical differences, like what does the building look like? A lot of times I've spent in conversations with patients who are transitioning, just kind of talking about like what you're going to see in our waiting room. An adult neurology waiting room is a lot different than what you see on the pediatric side. Obviously, the population is a lot older. It's a lot less colorful. There's nothing to do there. People wait for a long time. And having those kind of conversations before anybody's even entering into the waiting room and just knowing that that's what you're going to expect can really help just kind of smooth that over before you even enter the door. And then at the visit, like I mentioned, it's really important to bring your records with you to come on time, all of those type of things. Make sure you have your insurance. But then my last point there is also another important one and can be a challenging one. I really encourage people not to make any huge changes at that first visit because really we're talking about establishing that relationship, getting a chance for the adult provider to really understand who you are, what your history is. Most people who are coming specifically to an epilepsy specialty center have had a long history with seizures, have had prior treatments. Some have had prior surgeries, a lot of medications. And before any provider wants to get in there and manipulate that or potentially change it, you really have to understand what that history is, and you want them to. And that sometimes can take time. And so what I would say is allow that time. Allow, the first visit to go around with just relationship setting, with just information gathering, knowing that there will be time in the future to make any of the bigger changes that need to be made. Next slide, Adam. And then what happens after you transfer your care? You'll continue to get to know your adult providers. Obviously, I am a nurse practitioner, so I do like to kind of make another note here that in many adult epilepsy practices, Penn being one of them, you are managed by a care team as opposed to one provider. And sometimes that's a lot different for people. In my practice, I see patients very often to allow for improved access. And so we can increase the amount of appointments we're able to offer. And so our patients see a combination of a nurse practitioner sometimes, a doctor sometimes. We have social work involved. If you call, the nurses are the ones that you're talking to. So understanding what the care team looks like is also sometimes helpful. You're going to continue to build the skills that you need to manage your own care. Make sure that you let all of your pediatric patients know that you've successfully transferred your care. They like to hear about your successes. They want to make sure that you've landed safely somewhere. And the pediatric office may also reach out to you to see how the transition went. And I know that we have that relationship with some of our pediatric centers locally, and they love to hear those stories. Next slide. And then final notes from me. Transition is a valuable and medically necessary part of getting the care that you need as you mature. So people always ask the question, can I just stay with my pediatric neurologist forever? And my answer is no. And that wouldn't really serve you the best because as you get older, your body is an adult body, and adult bodies need adult doctors. There are a lot of other things that happen to people as they get older, and the adult providers are really looking to take the best care possible of you. Like Sarah mentioned and Adam mentioned before, transition looks different for every person. And so we really don't set guidelines based on a specific age. We really look at everybody individually. The most important part is that this is going to happen at a time that other things are stable for you. Transition of care from an adult to an adult practice is a big step. And so what we don't want to happen is people who are, newly pregnant, or newly having issues in school, or newly having an exacerbation of their seizures, and then we're throwing transition at them as well. So really, if we have to wait a little bit, or do it a little bit sooner to avoid another area of crisis and just focus on transition, that would be the best time. So my best advice is to talk to your pediatric neurologist about what that looks like for you. And then final note that I hope you take with you, it's never too early to start talking about transition. Early and often is good. Having a plan will really set you up for the best success possible. And with that, Adam, you can flip slides, and I am very pleased to introduce Diego to tell his story. Diego is a former patient of mine. I'm very happy to see him, and I will turn it over to you, Diego.
Awesome. Well, thank you, Bethany. And again, it's just, I'm honored to be here, and I'm happy that I was invited to be here because, I was a patient of Dr. Bethany Thomas, and during my transition, having her support was truly amazing. But, my transition wasn't also the smoothest. And, I wanted to share just a little bit about just sort of, I started having seizures in sixth grade. And then when I got to high school, I remember, actually, I was on multiple different medications. I started with Keppra, then I went to Depakote, and they didn't work. And then I got onto Triliptol, which I'm on today, and that was the medicine that worked for me, and that really helped stop my seizures. And then it wasn't until I got into college where then I started to kind of having more, just seeing things online and feeling like maybe I've grown out of my seizures. I used to read a lot of different things, and I started to kind of just in my head started to think maybe I don't want to take medication for the rest of my life. And so after college, when I moved out to the West Coast, where I'm at now, I'm in Oregon now. My mom wasn't there with me anymore, and she wasn't there to remind me to take my medication anymore. And I felt like, hey, maybe, I don't, maybe I could just stop this medication, and it just foolishly, I made a terrible decision that really led me to a lot of, where it led to almost, being dead because I had a seizure while driving, about to merge onto a highway. And that really, I remember my mom calling Bethany, I think while she was probably on vacation, and saying, Bethany, we need to get him his medication again. And, one of the things though I wanted to point out is the reason why I feel that I struggled though a lot and in my transition kind of getting to when I was fully independent was because of my mom being there for me always for everything. And Bethany probably remembers my mom coming in with her booklet with all these questions, and just, she would do all the talking and I would just more sit there. And I think that although my mom, I know, did all these things because she loves me so much, and she really, to this day, she still texts me and saying, hey, did you take your medication today? And, but with that, I think, again, it's sort of because of my dependency on my mom, I didn't have the opportunity, I think, through that transition to really learn what it's like to be an adult and make my own decisions. And again, I always tell my mom I love her and will always love her, but I did look at that as something that maybe hurt me in the long run. And it, again, I learned the hard way. And I hope that, when I get to share my story with folks like yourselves on this call, I share it because I hope that, you have many resources, which obviously you could see with Sarah's team and Adam, what they've put together. There's unlimited resources to really give you what you need to be prepared for adulthood and being able to make, smart decisions. And I think that if anything, words of advice here is that, there are resources out there, and the, CHOP it was amazing for me. But then when I got to Penn, I think if I were to look back at things, I wish that I would have taken advantage more of those resources, and also would have been able to maybe tell my mom, like, hey, mom, I think I can do this now. I want to go by myself. I think I want to be able to just be, me and Bethany, we can talk through things. And again, I appreciate all the love you have for me, but these were things that I wish I would have done, and I think would have given me a little bit more of a, understanding of just, being very careful when I'm making certain decisions. And so when I look back at things, I definitely, the biggest takeaway is that there's people out there that are there to help you, and definitely utilize them as resources. But then also, I would say for the parents is let your child or whoever you're caretaking also take personal ownership. And we're going to make mistakes, but we're going to learn from those mistakes. But if you don't allow us to make those mistakes, maybe, someone maybe will have to learn the hard way. And that was me, and I share that story because I hope that it does inspire, or at least, show folks that we have full control over our decisions that we make in life, and being able to truly, take the small steps rather than just going from 0 to 100, taking small steps to get there, I think is definitely something that I look back that I wish I would have done better. But I will say, in terms of, now being an adult, I always used to look at epilepsy as, a disability that I have. I can't do normal things that other people can do. And that may be true in certain ways, but at the same time, we have this amazing community. And so what I loved in this presentation that we also saw that, 1 in 3, folks have epilepsy. So there's a lot of us out there that are, going through the same things, and really take advantage of that community aspect, because we're all there to help support each other. And I'm very grateful for the team at CHOP and Penn, for all of the resources that they have. And they've actually included me in a lot of programs where now I get to talk with adolescents and, again, share my story and be a mentor for them and help them. But yeah, in terms of, I guess, biggest takeaways is, hopefully taking personal ownership earlier on, and learning how to, order your medication, learning all of those things, because I didn't learn all that until I was 21, when I was already living out here and figuring out stuff. And I think that was something that I wish I would have learned very much early on. And again, no fault to my mom. She loves me, and I love her. But I know, there's times where I think, when we turn 18, it's okay to be able to let, your child or who you're taking care of make those decisions. And yeah, and so I guess in terms of, what I wanted to share here, that was really, what I wanted to share with everybody here. And I just want to thank the team here, Adam, Sarah, Dr. Bethany Thomas, and Rena, for, allowing me to be here, and Lori as well. But yeah, thank you.
Wow, thank you guys so much. That was so informative. So many insightful suggestions and tips and strategies, really crucial information. Thank you guys again. We do have some questions. I'm going to throw it out to whoever wants to answer. So someone asked, what about if the parent gets power of attorney by age 16?
I'm happy. Excuse me. I'm happy to take that one. So that's perfectly fine. And power of attorneys and guardianship and healthcare representatives are all ways that you can help someone that you care for manage their own healthcare needs, and you can speak for them when they're not able to care for themselves. A healthcare power of attorney does exactly that. So if it's in place before the person turns 18, as long as it's still a valid healthcare power of attorney and the person hasn't revoked it, it's going to stay in place. I always like to, and part of my process is always asking people whether or not they have those documents, so that when I am sending patients to their adult providers, I'm also including that documentation. As Dr. Thomas said, when a parent calls Penn and asks to speak with their doctors, the answer is going to be no, unless there's very clear documentation explaining why this person has access to their chart. And a healthcare power of attorney is exactly that.
Thank you, Sarah. Another question, can a pediatric patient stay within the pediatric world till age 22, as is with their school district under the IEP process?
I'll take that.
Oh,
Oh, sorry, go ahead.
No.
So the answer is going to be different depending on where you're being seen. So there is not a hard, fast line there. Although I will say that many institutions, and maybe Adam, you could answer this a little better than I, but I'm aware of several pediatric institutions that are now drawing a line in the sand and saying that specifically in the hospital setting, they will not admit you if you are over 18 or if you are over 20. And so my answer to a question like that is, do you really want to be in a situation where you're followed by a pediatric neurologist who is just agreeing to keep you, but within a system that will not see you. And then just to get back to what I was saying about like being in crisis and needing transition, things can come up at any time. And I think our epilepsy patients really understand that and know that things can change at any time. And so if you are stable and staying with a neurologist and you're now 21, and then all of a sudden something changes for the negative and you end up needing to be hospitalized and you end up having to go to an adult hospital and there's no access to your pediatric provider, that might not be a situation that you want to be in. So again, transition looks different for everybody. In some places, yes, you may be able to stay, but there are going to be limitations the older the patient gets. And so as long as there is a plan in place for that, I don't think that there's a right or wrong answer. Adam, was that what you were going to say?
Oh yeah, yeah, of course. Yeah, I fully agree. I think it goes back to some of the concepts that Dr. Thomas was talking about earlier, is that really when a patient, if you're over 18 and stable, that's really the best time to do this, right? Because you don't want to end up in a situation where you're forced to have to go to a new institution that you haven't been to. In terms of it connecting to the IEP, that in terms of sort of the decision around transition is not connected to the IEP, even though it does go until 22. At least at CHOP, it's not, that doesn't stipulate that a patient can then stay until 22.
Okay, thank you both. Okay, so if an individual transfers to a provider who shares the same EMR, is it still necessary to bring MRI and medical records?
Another great question. So not always, but you can't assume that you don't need them. So there are definitely differences in what you're able to get through the electronic EMR. And some of that has to do with how the providers write their notes. And so some things are classified in different categories. And so even from Penn to CHOP, and we are on the same EMR, there are some providers that write their notes in different ways, and they are not accessible to me through the EMR. And so my recommendation is, if you are in a system that you suspect they can see it, you can easily call the office ahead of time. Just make sure that they have access to all of the notes that they need. The second piece of that is with the images. Reports are transferable through the EMR, but neurologists like to see pictures of your brain. And so they'll take the reports, but they're going to want those images on the disc. And there is no way to transfer those electronically through the EMR, even if they're the same system. So even if they tell you they have all of your records, you should assume that they have the reports and not the actual studies. And they will likely want those studies too.
Thank you. This question is specifically for Bethany. So what about a patient with IDD? Your presentation mentioned, people who are fully independent, but what about those with IDD?
Great question. Yeah, so the slides that I presented did skew towards folks who are more independent. Obviously, we could have many hours to talk about transition, and transition does look very different depending on what your capabilities are. For the patients specifically with IDD and severe IDD, we look more towards those legal changes, like Sarah mentioned, getting medical POA, getting those things set up. Guardianship is a big thing. But the rest of the logistics, so it takes away some of the conversation around, gaining independence, because that's not a realistic goal to be set for that patient population. But the rest of it, what the expectation setting is, all of those things still remain. But the focus really is more on the expectation of the caregiver and the parent in that setting, and making sure that their understanding of the differences between the adult world and the pediatric world, and what to expect and who to contact and what that system looks like, and really how we can best help them really integrate into that adult care world. Another thing that I just didn't have time to touch on that is really an important piece of this: a lot of these patients that we see specifically with IDD have a lot of different medical comorbidities. And one thing that adult healthcare systems don't do as well as pediatric care systems in general is coordinating care. And so we don't have clinics that are all kind of built together. I give this example all the time. People go to their pediatric neurologist and they can see physical therapy and then hop next door and see their psychiatrist and then hop next door and get their Botox, then see their neurologist, get their studies and be out the door in a day. And then you come over to the adult center and we tell you we don't have psychiatry here and Botox is done by physiatry, which is across town at a different location. And it's really just not in the same place. And so that can be very shocking for people if they don't know to expect that's what it's going to look like. And so more so for the patients who have IDD than others, just understanding kind of all of the aspects of care that are being provided by your pediatric specialist, and then having a plan to transition all of those aspects to the appropriate providers. And those are questions and a plan that your pediatric provider can kind of help you develop ahead of time.
Okay, great. This question's for Sarah. Will you fill out the 5 wishes with the patient or give it to the patient and family to do on their own time?
That's a great question. And the answer is that I'm available to go over that and fill that out with patients if that's what is their choice. So these conversations are really difficult and they don't always, they're not, they're difficult for any person, whether you have a chronic disease or not. Talking about what you want done in the event of an emergency is asking you to think about a lot of really uncomfortable things. I'm always honored when patients feel comfortable enough with me to walk them through that process. And so I go with whatever our patients want. Some patients, we work on these documents literally for years. Some patients want to take it and do it independently, either with themselves or with their parents or their siblings at home. I really take my cues from them as to their comfort level. So again, I'm available to do that, and most hospital social workers would be. So it's a service that's available for sure.
Okay, thank you. Okay. This person says, I am supportive of my daughter taking the lead with her epilepsy care, but she doesn't feel confident speaking to her doctors. What advice do you have for supporting her without pushing her too hard?
My recommendation would be to start small, that you can make transition goals that are very, very feasible and attainable. So, as our patients go through adolescence and start getting into those teen years, if they're in a position where they can gain independence, I encourage parents to say, okay, have the next time they come to the doctors, tell your patient or tell your child that they have to come up with one question for the doctor that's entirely independent from them, or allow them to speak to the doctor without you in the room, just to give them opportunity to be able to ask questions on their own or to advocate for themselves. I think that there are things that you can do in small steps. So my suggestion would be, think about what your end goal is. For example, if your end goal is to be able to fill medication independently, then maybe you backtrack and say, okay, well, the first time we're going to do it together. And then the next time you can do it and I'll be with you while you do it to make sure that everything goes okay. So if you take that approach with kind of all of the different areas of owning your own healthcare, you can probably come up with a plan that's a little bit more digestible.
Thank you. Okay. Would you suggest a power of attorney for a child who is deaf and has epilepsy? He is not mature enough at this time to make adult decisions and just turned 17.
That's a good question. So, it it really at that point they're still a minor, and so parents still have decision-making capacity. But I think that it's an important conversation to have with your son or daughter to see what they understand about their care and the implications of the care, and really to ask them what they would want to happen. So I think even if they're not ready to sign a POA, maybe even just to open the discussion, because really at 18, within a year, the law says, at least in Pennsylvania, unless we have documentation, otherwise we're presuming that you're competent. And so we're going to go to you to ask those questions. So I don't think you have to fill it out tomorrow, but I think again it's important to sort of open up those discussions and then maybe bring that to the provider and say, or Sarah, or if you have that social work support to sort of tease that out a little bit more.
Yeah, and sometimes I'll just add to that, Adam. Sometimes it has more to do with capacity and different levels of cognitive ability, and so definitely have that conversation with your provider because sometimes they can kind of help you, and sometimes that requires further cognitive or neuropsychiatry evaluation to kind of determine if there's competency there. But everybody's a lot different. So, having somebody who is deaf with epilepsy could mean a lot, right? And my own daughter, I can't imagine her ever being mature enough where I feel she's okay to make her decisions, but the law says at 18 she will, right? And so I think that there's like a comfort level there too, that's really hard. And so definitely lean on your current provider to help guide you with that.
Okay, we do have a few more questions. These are some great questions. So I apologize, we're going a little bit over, but we should be wrapping up soon. So even though my daughter is 18, if she signs a HIPAA release form, will that give me the ability as her mother to at least schedule transition appointments and talk to doctors about my daughter's history and care?
Yes. Yes. So if you are 18, you don't necessarily need to assign a parent as a POA or a decision maker for you to allow them to be an active participant in your care. So as long as you sign the right releases, like she mentioned, a HIPAA release, they will be able to talk to the medical team about the care, make appointments for them, request refills for them. And so that just needs to be documented.
Great. If someone is going out of town for college, is 18 still the best age for transition?
I think that this is a really complicated question and kind of like Adam's example from earlier. I don't think it's necessarily like a one size fits all. I will say that one of the things I do talk about with patients that are going out of school is ensuring that it's even more important to talk about ensuring that they have local care. So, for example, if you are going to school across the country, that you have established care with a neurologist that is going to be close to where you are, that knows you and that sees you. They can partner with another neurologist who is like in your hometown, but really ensuring that would be the priority, is ensuring that local care. So I don't think it's a hindrance to transition. I think it's just another transition to take place with all of the other things that sound like are happening right at that time for you.
And Sarah, I'll add to that real quick because for me, when I came out to Oregon, I didn't, and I live in a rural area now. It took a while for me to go see a I think it took over 6 months to go see a specialist. And so the earlier you can plan that ahead of time, I would say the better. So I had again learned that the hard way, but it's definitely not as easy to get care out here in Oregon where I'm at. I know as it was maybe back home in Philly, but yeah. Definitely, I would say that the earlier you can find that care wherever you're going to be living closer to you, the better.
Thank you.
I will add one more thing to that. Sorry, because I love that question. I actually think for people who are going away to college, that's a great time to transition to an adult center because there are a lot of activities that people participate in college that are adult activities that are not necessarily being addressed in a pediatric center. And so I think that for safety and for frank discussion around what I call the sex, drugs, and alcohol talk, I don't think that you're always going to get that in a different setting. And so for people who are going away to college, I think in some cases, it's even more important to transition that care to an adult practice.
Okay, this is officially the last question. How do you support patients who have home care and lose that benefit at age 21 or 22 through PA Medicaid? Is there support with waiver services at the adult level?
Yeah, I'm happy to take that question really quickly. So there are benefits. There are For some patients in Pennsylvania, there's what's called the Community Health Choices, which is a mechanism for paying for home care, nursing, or home health aid assistance. And then there are also waivers for patients. They're ODP through the Office of Developmental Programs that are consolidated waivers that provide funding for those supports as well. And really, they have different eligibility criteria, but I think the takeaway is yes, and that is something absolutely to have a discussion with, particularly your social work colleagues or case management staff that you might be working with about how to make sure you're registered for those services so you don't lose them at 21.
All right. Well, thank you so much. Thank you, Adam, Sarah, Bethany, Diego, and Lori. This has been such a wonderful pediatric epilepsy conference. Thank you for taking the time to share your knowledge with us. Just really quickly, I want to go over some stuff that's going on with the foundation. All right, let me share my PowerPoint here. So, we encourage you guys to stay connected to us, get involved. We have lots of programs and services. We have different events. We love to get everyone to share their story and advocate. Follow us on different social media platforms. We do have some upcoming events. And I will send this in the post email. So you'll have all the links and some information, but we do have the PA Treasury staff are going to present on financial empowerment, and they're going to have a Spanish webinar and an English webinar. And they're going to present on different opportunities that they have, like PA Able, 529, college and career savings program, and some other PA consumer programs. We do have an Empowerment Through Information Women's Health and Epilepsy Conference in person May 4th in Philly. We have our young adult retreat, so that's for 18 to 30-year-olds that are diagnosed with epilepsy. We have 2 walks coming up, our Walk for Epilepsy Greater Philadelphia in July, and our Walk for Epilepsy NEPA in September. We have our Camp Achieve for 8 to 17-year-olds that are diagnosed with epilepsy in August. And our Adult Wellness Weekend is for adults over 30 that either have epilepsy themselves, have a partner or a spouse with epilepsy, or have a child with epilepsy. And that'll be in September at Deer Park in New Hope. So thank you all for taking the time to be with us tonight. I'm going to quickly launch a post survey if you don't mind doing that. We have our website here and my contact if you need anything. So let me share real quick. Okay. All right, thanks everybody. If you could take a minute just to fill out the post survey, we would really appreciate it. And I will be sending everybody an email with some information about upcoming programs and services. Thanks, everybody.
Thank you.
Thank you, guys.
Thank you.
Thank you.
Okay, good night, everybody. Have a good rest of the evening.
Righty. It's great seeing you all.
Thanks,
Thank you.
Marina.
Thanks,
Thanks.
everybody.